we're going to do an interactive simulation. One of those cases that is complex will require you to think, and a variety of points during this simulation we're going to stop. We're going to ask the participants, which is you guys, in order to answer some of the questions. And then as a group, we're going to meet to discuss what we think is the best treatment options or the right answer from the selection that we have. I want to say first and foremost that this is a made-up case. It's not based on any actual child or young person that was injured. Second thing it's important to clarify is this is based on our interpretation of the current evidence base. And as with any journal, it can be interpreted in different ways. So we would strongly encourage you to go back to the literature, have a read for yourself, and to see what your interpretation might be. So before we start, we're going to do a brief round of introductions. So as mentioned, my name is Stephen Mullen, a consultant in the Paediatric Emergency Department, and I'll allow everybody a few seconds to introduce themselves.
I'm Tudor Oman. I'm a Paediatric Emergency Medicine consultant.
I'm Mary Beth. I am an ST5 in Paediatrics. I'm currently the Simulation Fellow in the Children's Hospital, and I am applying for Peds Emergency Medicine.
Dami?
I'm Dami. I'm currently ST6 in Pediatrics. I'm the NIMTA Simulation Fellow for the year, and I'm also applying for Paediatric Emergency Medicine.
And I'm Peter McAllister. I'm a Paediatric Emergency Medicine Registrar in Belfast.
So for the video we're about to show, the faculty or the participants have been all taken from ED. In real life, we would have a trauma team or a larger group of people involved. And this is mere reflection on just how we can access people in order to record this video. But we would expect if this case came through that we'd have our surgeons, our anaesthetic team, our orthopods and other members of the MDT.
Julianne, we've just had a short call. Okay, so I'm Julianne. I'm the consultant on today. I'm going to maybe put out a trauma call and assemble the team then for Emma, and you'll maybe give us the handover. No problem. Okay, great. So we've done that. Okay, guys, we've got a trauma standby. If everybody could just listen up, Emma is going to give us the handover, okay? And then we'll allocate roles.
So HEMS are at the scene. The incident occurred about 20 minutes ago. It's a 13-year-old boy who's been assaulted. He sustained 2 stab wounds, one to his left anterior neck, as well as the left anterior chest wall. His heart rate at the minute is 130, blood pressure 110/70, saturation's 95. There's increased work of breathing with some subcostal recession. GCS is 15. HEMS have got IV access. There's 2 cannulas. He's already had his loading dose of TXA. There's 1 unit of packed red cells currently running. He's also had ketamine, and there's dressings applied to the wounds. And the estimated time of arrival is 5 minutes.
Okay, guys, so thanks, Emma. So we've basically got a 13-year-old coming who's got penetrating chest trauma and also a neck wound. We've already got some hemodynamic instability there, and there's blood being given at the scene. So, guys, we'll run through introductions and your designation, first of all, and we'll go from there.
My name is Dami, Paediatric Reg, and I'll manage the airway.
Okay, Dami, so obviously we're really worried this child's critically unwell. We may need to proceed to early intubation. Are you comfortable and competent to do that?
Happy and confident.
Great.
Hi, I'm Peter, PM Reg. I'm going to be managing breathing.
Okay, Peter, so again, penetrating chest trauma here, we're going to need to think about early chest drain insertion. Are you comfortable and competent to do that?
Yeah, I am.
Great.
Hi, I'm Jane. I'm one of the earlier ED consultants, and I am C doctor today.
Okay, Jane, so obviously, again, we are worried about the circulation already. We do have vascular access already, but we might require intraosseous access.
Yep.
Great.
Chloe, PhD nurse. I'm happy to assist with airway.
Thanks, Chloe.
I'm Claire. I'm one of the PEDS EMPs, and I'm breathing nurse today.
Thanks, Claire.
Hi, I'm Lucy. I'm one of the PhD nurses, and I'm happy to assist with circulation.
Thank you.
Hi, I'm Colin, paediatric nurse, and I'll be doing the run.
Thank you.
I'm Emma, AMP. I'm happy, whatever you need me to do.
Great. Emma, if you're able to maybe check the electronic care record for us for any previous attendances or any other history we can get. And we're going to need to do a stab check on this patient as part of our primary survey. So I'm going to give you responsibility for that, if that's okay, and feed that back to me. Thank you.
And hi, I'm Alex. I'm a PhD nurse and I'm going to be the scribe.
Okay, great, guys. So talking about those priorities then, I think we just get a few minutes to get organised and then I think the patient's going to arrive.
Yeah, Gillian, actually, I think we should activate the major transfusion protocol.
We've got blood in the department. Sorry, Jane.
You've got a wee bit of blood, but sure, it takes ages for the rest of the blood to come.
Yeah, but blood's kind of precious, so I don't think we should initiate the major hemorrhage protocol.
Okay, but is this not exactly when we should? He's been stabbed, he's had blood in the way. I don't know, Gillian, what do you think?
So now we've reached the first intermission. So the first question we have is, when would you activate the major hemorrhage protocol for paediatric trauma? And we're giving you 5 options to pick from. So option A, after 2 units of O negative administered. Option B, only if the patient is hypotensive. Option C, we don't need to activate in pediatrics. Option D, I activate it in all trauma patients. Option E, a patient with normal OBS but concerns of significant blood loss, I would consider activating it. So if you can put your answers up in the live chat, we'll give you approximately 30 to 60 seconds to respond, and then we'll start discussing some of the answers. So it seems to be in agreement what we would stipulate, which would be option E, and we'll talk about the pros and cons of all the other options as we go through. First thing we need to discuss about is what actually is a major hemorrhage, as that would prelude us to activating the major hemorrhage protocol. And it's important to acknowledge that in ED, when we see the patients, it's often difficult to appreciate how much blood has been lost. There might be some lost at scene, there might be some cavities in the abdominal cavity or pelvis that we're not able to actually see, or retroperitoneal, so even if you used your other adjuncts. But when we look at definitions worldwide, we've got, in terms of volume, 80 mils per kilo over a 24-hour period, 40 mils per kilo over a 3-hour period, or 3 mils per kilo per minute. And those definitions are very difficult for me to envision in my head when the patients come through. So I don't think they're particularly useful for ED, but they're definitely worthwhile actually having a little bit of knowledge. The patient, what I see, will be in a journey. I don't know how much blood they've lost, and I don't know how much blood they're going to lose. So you almost need to anticipate what's coming through. And there's a balance that we're trying to acquire. So we want blood products available for resuscitation versus not wasting blood products. So we know blood is a finite resource. O negative in particular, the stocks I think are low, certainly UK-wide for a period of time. And if you call your major hemorrhage protocol and you waste those products, you're depriving other people from getting access to those. On the other hand, if you have delay in blood products, we know there's an increase in mortality. So a single center study from the US was able to identify that for every 1 minute delay in you getting your hands on your major hemorrhage protocol, or PACS, there was a 5% increase in mortality. Now, this was a single center adult study, and there's no comparable pediatric data, but it certainly should give you a little bit of information to empower you to think, what time frame do I want? You need to think about your unit and how long it takes these PACs to arrive to your ED. Factor in the activation time, defrost time, and transport time. So we know FFP takes approximately 20 minutes to be defrosted. Transport time can vary anywhere between 2, 3, and 20 minutes as well. So if you want your pack and you're waiting to activate it, by the time you activate it till it arrives in your hand, can be as high as 40 minutes. And I would strongly encourage you to go back to your department and run simulations in order to have a look at this. And why do we want the blood packs for? Well, we know the balanced resuscitation is much better for trauma patients rather than just giving them either salty water or packed red cells. When you bleed, you don't just lose red blood cells. You use plasma, clotting factors, and platelets. And by doing this balanced resuscitation, we're able to improve outcomes. And certainly it's gone from balanced resuscitation 1-to-1-to-1 to starting to look at whole blood transfusion, which is something that is definitely coming in through the research. If we're thinking about our parameters and how to activate our major hemorrhage protocol, we were very fortunate to be involved in a piece of work that we published a year or two ago, looking at pediatric trauma patients and their vital signs when they were getting transfused, either pre-hospitally or in the ED. The vast majority of these patients had normal blood pressures and a slightly elevated heart rate. And we often think of our hemorrhagic trauma patients as displaying hemorrhagic shock. So they're all tachycardic. they're all hypotensive, and that's not the case for pediatric patients. And they're very different in how they manage blood loss. So some of the evidence would say that for an adult, myself, if I lose 10% of my circulating volume, I will drop my blood pressure, I will get tachy, I will look unwell. Pediatric patients, before they display those signs, is up to 40% blood loss, which is incredible. And when you think of the small baby in front of you that might be 10 kilos, their circulating volume might only be 800 mils. So if there's 100 mils on the floor, 100 mils in the abdominal cavity, you certainly mightn't appreciate it as much as you would do. It's also how kids are able to respond differently, in that they're able to put their heart rate up to rates that we can't get as adults, but also increase their systemic vascular resistance in order to maintain their blood pressure. So therefore, we don't tend to see the hemorrhagic shock that we would see in the adults come through. So what is driving us to administer blood products? Well, sometimes it's the history that comes through and in terms of activating. So if I know I've got a penetrating injury, I know if there's blood been given at scene, if there's traumatic cardiac arrest, I will certainly lower my threshold for activating it. I'm not completely reassured by having normal OBS in a patient who maybe looks a little bit unwell, in that clinical gestalt that we use in order to try and help transfuser population. We're probably potentially under-recognizing it as well. If we look at the survival outcomes coming from some US data, we know that for hemorrhagic shock in the adult population, the mortality rate's about 25%, whereas in pediatrics is between 35 and 50%. So my take home from this is just basically the answer that you give, is that you need to anticipate the time it takes for your blood products to arrive. Even if you have packed red cells in your department, you want to do balanced resuscitation. So you need your FFP, you need your platelets, you need to consider your cryoprecipitate. You need to be aware of the timing and how long it takes for them to get into your department, and also not be completely reassured just because you've got a child who's got normal observations. So I'm going to hand over to the panel and see if there's anybody else wants to add anything else in from their point of view about when they would consider activating, or any deviation from my humble opinion. And I think that's been a long enough uncomfortable silence. So we will crack on back to the video and see what this team decided to do.
Okay, Jane. So basically what we know at this stage is we've got a hemodynamically unstable patient who's receiving blood at the scene. There may be some blood loss at the scene. So I think go ahead and activate the major hemorrhage protocol at this stage. And if you can just confirm back to me when you've done that, thank you.
Yeah, okay, let's do that.
All right, how's it going?
Hi, Davey, how are you?
You boss?
Yes, I'm Julianne Collins. I'm the trauma team lead today.
This is Tommy.
Okay.
He's 13. Pretty much you got the app missed. His obs have stayed unchanged. He's got a couple of stab wounds, neck and chest that we found. We've dressed him,
Great,
given him
thank
his TXA, and we have blood going.
Okay.
I managed to get a picture of the knife.
Oh, great, thank you.
So I'll let you see that. And other than that, he's as you find him.
And any blood at the scene, really, David?
Yes, a fair bit of blood loss at the scene.
Okay, great.
All right.
Okay, guys, so we're going to jump in and quickly do our primary survey of the CABCDE approach. So looking for any obvious catastrophic hemorrhage initially. Don't think there's any ongoing active bleeding. I'm going to give you a few minutes just to assess your areas, and then I'm going to get you to feed back to me what you found. Okay, starting with you, Dami, up there at the top end.
Julian, airways bleeding. He's bleeding on his own. He's got an anterior neck chest wound, anterior neck wound that doesn't seem to be actively bleeding. It looks superficial. There's no tracheal deviation. I'm happy with his airway at the moment.
Okay, so you mentioned there obviously we have a neck wound. We don't think from the history that there's really risk of cervical spine injury. However, we don't have further information at this time. The wound that we see there we think is superficial, but we'll need to explore it further. I think we'll perform manual inline stabilisation at this stage, Dami, until we know more. Okay, Peter, breathing?
So our SATs are 92, 93 on 15 litres. We've got good energy on the right side. Left side reduced energy at the base, and you've got looks like a stab wound, kind of left anterior chest, that's dressed at the minute. So a bit worried about the chest.
Okay, so we're not happy with the chest. Yes, Jane?
I'm not happy at all. He's freezing. He's really shut down peripherally. He's tachycardic, real thready pulse, about 140. Cap refills 4. Not a lot of blood to be seen. The dressings are on. He's got good IV access, but I'm not happy at all.
Okay, so at this stage we're worried about chest, we're worried about circulation. We'll maybe just do the stab check just to make sure we found all injuries. So if we can do a gentle log roll, guys, 15 degrees on your account, Dami.
1, 2, 3, roll.
Julianne, there's actually a chest wound now to his right posterior chest wall as well.
Okay.
No long bone injuries and tummy is soft.
Okay. So as part of that, we've checked the axilla, we've checked the buttocks and the groin and the back. So we found a further stab wound. So we've got 3 stab wounds, which we've now dressed at this stage. Okay, so we're really concerned about the chest. There could be hemopneumothorax. We're worried, obviously, that we're still very tachycardic. Blood pressure is definitely borderline. That we've got hemorrhagic shock, possibly.
Claire, do you have a POCUS or an ultrasound in this department? I think we need to ultrasound him.
Sorry, Jane. I know you work in adult DD and ultrasound, anything that moves, but we don't use POCUS in paediatric trauma.
Okay, but I can do it, so I'm just going to do it, yeah.
No, because I think it'll distract from what we need to do for this kid, so I think we should focus on other things. Is that okay?
Okay, no, it's not okay. What do you think, Julianne?
Okay, so we're going to move on to our second question then. So this question is about the use of POCUS, so point of care ultrasound in the severely injured child, and you've got 5 options which we'll go through, and you'll vote in the same way as you did in the first question. So option A is that a sensitivity of a fast scan is over 80%. If a POCUS is negative, it means that you do not need to do a CT scan. C, POCUS is poor at ruling out or in pneumothorax in paediatrics, given the elasticity of the ribs of the child and the high chest compliance. D, that POCUS is very user dependent, and E, should never be used in paediatric trauma as it just delays cross-sectional imaging. So if you vote now, we'll have a look at what your answers are, and then we'll have a bit of a chat about things. Okay, so option D seems to be the most common one for now. We'll bounce back to the questions in a second, just so we can go through the options, and then we'll have a bit of a chat with the panel and discuss things. So option D seems to be the most popular now. We'll go back. So the most popular answer is that POCUS in the severely injured child is very user dependent, which I think is very, very true. A lot of obviously what we do in paediatric trauma comes from the adult population, and in adults, often people who come in severely injured get a fast scan done. So for those who don't know, it's a quick ultrasound in 6 areas, both lungs, heart, and then 3 right upper colon, left upper colon, and the pelvis. And adult emergency medicine physicians become experts really in this, and they're very, very good and capable of finding pathology, so free fluid in the abdomen, pneumothoraces, hemothoraces, pericardial effusions, etc. So do we then just extend that knowledge and expertise to the paediatric population? And that's I suppose the question, isn't it? Do we just fast scan all patients? And the data for this is limited. There aren't any RCTs looking at the diagnostics or survival characteristics of POCUS versus CT on its own. However, there is emergent evidence that POCUS has a role in the primary surgery in detecting significant injuries in patients presenting with blunt or penetrating trauma, especially chest trauma, so pneumothoraces, hemothoraces, etc. And also, as a side note of that, has a role with the insertion of a chest drain. New European Resource Council guidelines for paediatric trauma and the unwell child mentions POCUS a lot, so it's mentioned for as part of the primary survey for chest injuries and cardiac arrest and the assessment of shock, IV access. So there's definitely a movement in paediatrics to the use of point of care ultrasound a little bit more, but it's definitely very user dependent. Obviously, we as emergency medicine doctors can do courses, CACTS courses, for example, but paediatric trauma is still rare, and picking up those things because it doesn't happen very often, and there's limited kind of pick-up rate with regards to that. There is a 2021 study by Liang, which is a systematic review which looked at over 2,000 patients presenting with blunt abdominal trauma, and it showed that there's a high specificity. So if there was evidence of an intra-abdominal injury on the ultrasound, free fluid, for example, then there was a high chance that they would have something on their CT subsequently, but there was a low sensitivity. So if the scan was negative, then you were still having to do cross-sectional imaging, and it doesn't preclude the need for a CT. So that does kind of bring the question up. So should we fast scan all children? Should we do a more focused POCUS, for example, on the chest to assess both lungs and the heart? with regards to the specifics for them. And that's something we'll bring to the panel in a little second. And also, I think it's important to mention that as hopefully you've learned through your careers in paediatrics, that children are not small adults, and they've different mechanisms of injuries. Intra-abdominal organs are proportionally larger, and there's less abdominal protection. The spleen and liver are lower and more anterior. There's less protection from the ribs, as mentioned in the questions as well. Diaphragm is more horizontal, and sometimes a little bit of free fluid can be normal. So again, brings in that huge user dependence issue whenever it comes to the management of a severely injured child, and the stress that brings within the team as well. So I suppose just wanted to bring that question to the rest of the panel with regard to this question. Is a chest focus reasonable and avoid the tummy? Is that kind of where we think things are moving to?
I'd probably agree with you. I think there is a benefit in being able to take out your probe, particularly for those critically unwell children. So for trauma, which is the emphasis of this talk, I think being able to decipher whether there's pericardial infusion, a tamponade, how the heart is working, and then also be able to rule out a pneumothorax or a hemothorax, or confirm or help confirm is useful information to have whenever the patient is too unstable to go somewhere else. So I don't know what anyone else think. I was a big advocate for POCUS, really thought it was going to change the world based on the fact that it was bedside test, there was no radiation, it would be relatively easy to do. But as I've got a little bit older in the tooth, I'm still on the fence of its role really in peds emergency. I think with chest, there's definitely a role, but it'll be interesting to see what other people's thoughts are.
I think it's playing an increasing role in what we do. I'm definitely using it more in the resuscitation, often for cardiac standstill, tamponade, chest. That's the area that is used the most. This one was about a fast scan. And I think in that circumstance, maybe using it for a sequential follow-up rather than having to run to CT every time you think that there is something else going on. CT is a static image in time. This offers you a chance to sort of monitor the patient as well. And I think that's something we can look at, but the evidence isn't necessarily there yet. Definitely useful.
I'm a big fan of POCUS. I think it's silly to ignore information that you can get fairly easily, as long as it doesn't distract from other things, and as long as you're aware of the limitations of what it can and can't do. I think it would be silly to ignore it. Certainly I've used it to stop people ready to put a chest drain in, and was scanned and said actually there's no pneumothorax there, and there's no hemothorax, so you can avoid doing harm to your patients, but as you say, as long as it doesn't distract from important things and you're aware of the limitations.
Great stuff. So yeah, I think the consensus is that POCUS, especially for chest pathology, can be very helpful, and as long as it's in the right hands, and as long as it doesn't distract away from patient management directly, and it's very helpful at giving a dynamic picture of the patient's pathology, and that's that study that we're talking about already. So I think we're ready to move on to the next section, Tudor.
Okay, Jane. So I think actually if you could focus on the chest ultrasound for me, so I want you to look at the lung and the cardiac views, and if you could just report back to me, that would be great. Thank you.
Okay, so there's absence of lung sliding on the left. I think there's probably pneumothorax there as well. Nothing really too exciting in the heart, and the right looks okay. So I think you've got a left pneumothorax.
Okay, so left pneumothorax. Okay, I think at this point, guys, we'll maybe just take a little pause just to recap where we are and where we're going to next. So obviously we've got a critically unwell 13-year-old here who's got penetrating chest trauma and another 2 stab wounds as well. We've identified we've got a left pneumothorax, so I think we need to urgently proceed to a left side of thoracostomy followed by chest drain, Peter, if you can organise for that. We do need to optimise our oxygenation as well, Dami, so we may need to start thinking about prepping for intubation. Obviously really worried that we're very hemodynamically unstable here, we're very tachycardic, we're hypotensive, so we need to get rapid volume replacement in. Did we hear back about our major hemorrhage protocol?
That's right.
So we've got all of our blood products. Okay, great. So if we can push those, our packed red cells, our FFP and platelets at a ratio of 1 to 1 to 1. And again, just keep me updated as to what we've got through, and Alex is keeping a note as well. We're going to proceed. We've had a tranexamic acid bolus at the pre-hospital scene, so if we can proceed with tranexamic acid infusion. Great. Emma, have you managed to find anything out on electronic care record at all that might help us?
Yes, I looked on Epic and also spoke to his parents. There's no significant medical history. He's no allergies, not on any medication, but he was in a couple of months ago with intoxication and also an e-scooter injury last month.
Okay, so there's been some previous attendance, okay. Okay, guys, I guess anybody else in the team, anything else to add at this point?
Blood gas is here, Julianne.
Okay, great. What have we got?
He's not well at all. Lactate's up, profound metabolic acidosis, hemoglobin's a wee bit down. That's about it.
Here is calcium's also a bit low.
Oh yeah, it's calcium's low, yeah.
He's also really cold. His temperature's 33.4.
Okay, so a low calcium and hypothermic as well as severely acidotic.
We need to treat those, do we?
So that brings us nicely into question 3. So what is the most appropriate immediate management? So A, actively rewarm and administer IV calcium. B, aim for hypothermia 32 to 34 to reduce the risk of brain injury. C, delay calcium replacement until hypocalcemia is less than 0.6 millimoles per litre. Or D, focus solely on volume resuscitation. Calcium and temperature correction are not priorities in the first hour. So if you want to vote now, we'll give you sort of 36 to 60 seconds for that. Yeah, so most people are voting for option A there, so actively rewarm and give IV calcium. So we'll just give a little bit more time just to see votes coming through. Okay, so I think the first thing to say is that actually how that information came about in the scenario is actually a lovely demonstration of the flattening of the hierarchy there, allowing information from any team member, which actually can have a huge impact to the care. So what we gained there was information on our temperature and our calcium, both important considerations, but not easily revealed when we're initially going through our ABC and focusing on our breathing, circulation, chest drains, etc. So we'll talk about both now in a little bit, and we'll start off with hypothermia. So part of our lethal triad alongside our acidosis and coagulopathy, and we know that they all feed into each other, making our resuscitation a bit more difficult. So how common is hypothermia? So if we think about it, if we think about the environment when we usually find our trauma patients, so we live in Northern Ireland, wet, drizzly, cold, as is today's November day. Ambulances, helicopters, we don't really see them as warm places. We often strip our children down to find out what their injuries are, and we might not cover them back up. We also bring them into resuscitation bays, doors opening and closing all the time as we need to add and teams, etc. So it can happen quickly, and there is a big evidence base there to say that it can have negative impacts on our patients. So a systematic review and meta-analysis from 2020, actually in the adult population, looked at mortality, and it was 5 times higher in all trauma patients in the hypothermic patient compared to the normothermic patient, and 2 times higher in those with traumatic brain injury specifically. In pediatrics, there's less information available, but a single center study in the American Journal of Emergency Medicine showed that actually in just under 3 years in their department, pediatric patients who were hypothermic showed a 9 times increase in mortality. So not a small risk, and it's quite a small thing to check a temperature, but it might be down our list of priorities. But it is a huge impact to patients, and I suppose it's important to recognise that A, it can happen, and B, that there's actually simple things that we can do. So removing wet clothes, covering patients back up, giving them warm blood and fluids, or bear huggers are sort of simple things that we can make. And if we can have a think about how that comes into our practice and how we designate that at the start so it's not forgotten about is actually a really useful thing. So maybe having someone who knows their role in the situation is to make sure we get a temperature is important. I'll go to the panel first to see if anyone has anything they want to add on hypothermia, and then we'll move on to hypocalcemia. Anything you think of, anyone?
No, I think you're very right there, and that it's something that when you're the trauma team lead, you're often so fixated on getting the airway secured, thinking about a chest drain, getting your volume replacement, that temperature, because it features so low down your list of priorities is often forgotten. And I think the evidence base is increasing our awareness of the importance of hypothermia. And you're right, easily identified and easily fixed. And that flattening of the hierarchy that this simulation showed isn't easy to achieve in some departments. There is a clear hierarchy, and what you really want is that piece of vital information to be passed on to the team. So when you're teaching or educating or setting up your team, then I think it's really important that that's put out there quite early.
Okay, well, we'll move on to hypocalcemia then. So I suppose it's been increasingly recognised as being important, and actually people have proposed the lethal diamond in adding hypocalcemia to that triad that we've already discussed. A systematic review of meta-analysis from 2021 showed that 50% of adult trauma patients were hypocalcemic on arrival, and the evidence is that there's about 2 times increase in mortality in those patients. So what's its importance in paediatrics, I suppose? There's less evidence out there for paediatrics. There's less evidence on its incidence. A meta-analysis had showed that there was about a 1 in 6 incidence, or 15% of patients, paediatric patients with trauma, were hypocalcemic. So not insignificant. Stephen and I did a systematic review trying to find out some more information about this. And actually we were only able to identify 2 studies who looked at hypocalcemia and paediatric patients. And the studies had relatively small numbers. They weren't well powered to achieve statistical significance, but they did show trends towards increased mortality and the increased need for blood transfusions in these patients. I suppose it's somewhere that we need to look for more information, and Pruki are currently carrying out a study looking at the effect of hypocalcemia on patients' hemodynamic stability and their outcomes, which is going on at the minute. I suppose it's important to recognise that in addition to whether hypocalcemia is present initially or whether it's something that develops during a resuscitation as we administer blood products. In this case, we've got the massive hemorrhage protocol. It's important to recognise the role that giving citric-containing blood products has on reducing our ionized calcium. So having that awareness in your head while you're administering those things, keeping a check on your blood gas, looking at the calcium, is really important. And I think that although there's less evidence in children, I hope we've managed to convince you that there's enough evidence there to consider hypothermia and hypocalcemia and actively intervene in the early stages of resuscitation, because sometimes it takes us a while to realise those things. Does anyone have anything to add, or any evidence you think I've missed or anything? Oh, sorry, Stephen, were you going to say something?
No, I was about to say nothing. Actually, we just kick on and see what the next, what people decided to do during the resuscitation.
Thank you both. I think they're great questions. So yes, I think we're going to actively rewarm this patient so we can put the bear hugger on, and I think we should treat the hypocalcemia. So if we can go ahead and draw up tables of 10% calcium gluconate and let me know when that's been done, that would be great. So really worried about this patient. Looking at the monitor there, guys, I think we need to sort of think, are we going to be able to stabilise this patient enough to get to CT scan, or are we going to have to go straight to theatre at this point? So,
did you get your drain in, Peter?
Yeah, drain's in.
Well
there's
done.
about 200 mils, thanks. There's about 200 mils of blood draining, and it's swinging and bubbling.
Well, I'm not surprised because he looks absolutely awful.
Okay,
we're
Jane,
not winning here at all, Julianne. That
okay,
pulse is
Jane,
very
can you
steady.
keep your finger on that pulse then? I'm worried that this patient could arrest any second on us here.
Yeah. It's gone. He's arrested.
Sorry, Emma. I think we need to stop chest compressions. If that's okay. This is a traumatic cardiac arrest, and there's other priorities. So can we stop chest compressions?
But sure, for cardiac arrest, you give chest compressions. I've done my PLS.
Yeah, no, you're right. But in this kind of specific situation, we need to focus on other things. There's a bundle that we need to focus on. So can we stop chest compressions and we'll look at other things?
Are you sure, Julianne? What do you think?
And yeah, that brings us to our next question. So we have a patient who's arrested in front of us. Do we compress the chest, or do we stop chest compressions? And as we voted before, just pop your answer into the chat. So option A would be chest compressions must be done. B, I would consider stopping chest compressions, but in truth, I would find this hard to do. C, I would temporarily stop chest compressions until thoracostomies are performed. D, I would stop chest compressions until the life-saving bundle has been initiated and then restart. So we'll give you about 60 seconds to put your answers in, and then we'll have a chat. I think most of us have gone for C. We'll just give a few more seconds to get more answers in, and then we'll go to the discussion. So on to the discussion. So I think everyone here would appreciate that having a patient in arrest in front of us and not doing chest compressions is something that feels unreal, because it's been drilled into us all from very early on. If a patient is in arrest, you have to do chest compressions. But we have to think along the lines of, what are we trying to achieve when we actually deliver chest compressions? So we think back to the physiology. Now we have a patient who is in arrest, and we're delivering mechanical pressure to the chest. And what we're aiming to achieve is to generate enough pressure to deliver an ejection fraction, perfuse the heart, and also perfuse vital organs. Now, if we think in the context of a patient who's in traumatic cardiac arrest, and we're conscious of the fact that one of the things that will be happening in the background is loss of circulating volume. If we do not have volume circulating and we're delivering mechanical pressure to the chest, what are we actually circulating in this case? So if we think about what we know about children, and that one of the primary things that happens when they're in arrest is loss of volume, especially going back to what Stephen has said earlier about loss, how much loss of volume affects children. We then have to pull back and think, what are the things I have to actually do to ensure when I want to resuscitate this child to have the most benefit? When it comes to evidence of what we do and why we do what we do, there's not a lot, but there's a general consensus, be it with your ATLS, your APLS, or ETC, that we have to prioritize the life-saving bundle before we actually proceed down the line of resuscitation. What are the things we're thinking of in the life-saving bundle? We have to focus on our reversible causes, and we have to think of our HOTT. Again, I take us back to what we're all very used to. We're used to our 4 H's and 4 T's, but in trauma, we tend to veer off that and focus on the main 4 things we're thinking of. Your first H, we're thinking of volume. We have to think of actually rapidly replacing the volume. We have to think of oxygenation, and we have to think of tension pneumothorax and tamponade, which are the things we have to prioritize. In this case, there is, I think it was by Vassallo and the others in about 2018, there was a consensus that was reached at the time using, I think it was a Delphi study, where they had a room full of professionals who sat and, you're thinking along the lines of, what are the thoughts you have? How do we best deliver care in this scenario? And one of the things they had come up with, which is what we base our approach on in pediatrics, is when we think of cardiac arrest in the context of trauma, we've lost our output. We have to prioritize a few things. First things is we have to think of hemorrhage. Have we arrested any visible hemorrhage we can't see? Then we have to think of oxygenation and ventilating our patients. Do we have a secure airway? Are we ventilating okay? And we have to think of thoracostomies, which also fits into the early part of the scenario when Peter, advocated for, let's get the chest drains in. And we also have to think of rapid volume replacement, which is why we talked about the major hemorrhage protocol activation early enough. Because if we don't have volume, then our chest compressions are going to be futile. And then when we think of replacement as well, we have to then think in the context of, if this is blunt trauma, because we're talking about trauma in this scenario in the context of penetrating trauma. If it's blunt, you can't see any active bleeding, but we still have to be thinking along the lines of, is there some hidden bleeding inside? And our pelvic blinder comes useful in this scenario. So I'm also going to open up that to discussion about, there is a study as well that was done. It's an animal study that talked about a study done on animals, and then they thought about looking at different interventions in different groups. They found that the group that received chest compressions alone or chest compressions with other interventions actually had poorer outcomes. The interventions actually had poorer outcomes. outcomes. Now, we also know there's a thought that when we're delivering chest compressions to a patient who has no circulating volume, we're actually at risk of increasing intrathoracic pressure, which might actually even worsen the bleeding and worsen outcome for these patients. I'll open it up to other members of the panel to see what other thoughts they have and what's been happening in practice for us as well.
So I suppose we'd be interested to see in the panel what people do in real life. So what my practice would usually be is, I think if you're going to do bilateral thoracostomies, you have a scalpel in your hand. If somebody's doing chest compressions, you're putting the patient at injury and also your staff from sharp injury. So my practice is to temporarily pause chest compressions while we get these interventions done. What does the rest of the group do? I know these are rare scenarios, but in your head, if you got a mental model, what are you thinking?
So from some of the traumas that we've had, my thought is that when you have a medical cardiac arrest, you're trying to limit the time off the chest. So you're trying to get your ultrasound in there in between during the pulse check. In a traumatic cardiac arrest, I have less concern about saying, let's get off so that we can get a few tasks done, because the evidence shows that we need to sort of try and fill this patient back up again, deal with the pneumothoraces, the hemothorax. So I have less concern about that, but I still think it's very hard for the team for you to stop chest compressions altogether. So I think in between those activities happening, chest compressions back on again.
I think as well, as a trauma team leader, it's helpful as part of your pre-brief for your team to mention that if this is a traumatic cardiac arrest, that you say that if there is a traumatic cardiac arrest, then we might stop chest compressions until we do X, Y, and Z. So it's a good thing to bring up, I think, as a trauma team leader, so the team are prepared, so there's less of a moral injury as a result of that, because it's very difficult, especially if there's less experienced staff within the room, to have a cardiac arrest but no ongoing chest compressions. So something to consider.
Anybody do anything differently? I think really want to emphasize this is our interpretation. So for your departments, you should discuss with your team to see what you would do. And we don't advocate not doing chest compressions, but if it's going to put the patient or somebody else at harm, then I personally stop it. Using POCUS, does that change what you would do? Because taking on Chris's point about you put an ultrasound on the chest, you're able to ascertain if there's a pneumothorax or a hemothorax there. And if you'd done one and it was negative, would you continue to do chest compressions because you're not going to do your thoracostomies, or would you still do your thoracostomies and stop? What do you think?
I've had a little bit of experience in that there's a couple of times in which we've done prolonged resuscitation and thought of discontinuing, and the ultrasound has changed it, because as we put the ultrasound on, we can still see a heart beating. That's a different scenario to what you're asking, but what I'm saying is POCUS does have an influence on what you do, and just because you might not feel pulse because of low volume, it doesn't mean that the heart is not beating. As for whether I would do it, I think if we are in a situation in which we are not getting anywhere, then yes, I probably would consider still doing it, but it's case by case, I think, depending on what kind of trauma you're dealing with as well.
I think
what would you do, Stephen?
So I was going to say I'd probably be in agreement with you. So I think the low sensitivities for your pneumothorax and your hemothorax would mean that even a negative ultrasound doesn't say there's not one there. And I think the updated guidance from the Resus Council has advocated for the use of bilateral thoracostomies even in the absence of signs of pneumothorax or hemothorax. Now, they don't specifically say on ultrasound, they just say it's a general term on the absence. So I think this is particularly a question, it's a grey area where it's open to interpretation, your resources and your expertise. But what I would advocate is that you think about these before the case actually comes in, because this discussion can go on for a little bit of time. And if you've got a case in front of you, you want to really have thought of your answer beforehand. So will we go on to see what the team has decided to do?
Okay, guys, so this is a traumatic cardiac arrest. So I think we're going to deprioritise chest compressions at the moment, Emma. We're going to focus on our life-saving bundle. So we really want to address oxygenation and optimise. We talked about getting ready for intubation, Dami, so if we can proceed to get further organised for that. We've got our left-sided chest in situ. We need a right-sided thoracostomy. If
Yeah,
you can
that's
crack on
done.
with that, Jane, great. We obviously need to continue with our rapid volume replacement. So how are we getting on there so far? Still ongoing.
Second unit of blood's going up now.
Okay. So we need to continue with that. We've addressed so that's our hypovolemia. We've addressed our oxygenation. We've addressed any obstruction from attention pneumothorax by putting in the drain on the left side. I suppose we need to think about a tamponade.
Well, POCUS, the heart looked okay. Julianne, tubes in.
Okay, so perfect. Okay, great.
Right, guys, how long are we doing this for? With still no pulse?
I think that's 6 minutes now.
What do you think? Should we crack chest?
Should we?
I'm going to talk to you a bit about cracking the chest. And we have a question for you, but I thought just in case there are a few in the audience who are maybe not familiar with this, I just wanted to highlight what we're talking about. So we've talked about the bundle of life-saving interventions, and one of those interventions is putting in a bilateral thoracostomy. A thoracostomy is basically doing what you do with a chest drain, but not putting the tube in, just leaving a gap in the side of the chest into the lungs to allow for blood and air to come out, to release the pressure around the lungs, allow the lungs to reinflate, but also to allow the heart to beat without restraint. So the next step onto this, you see a big arrow pointing down, would be to consider you've got ongoing cardiac arrest and you've maybe got no real response to this life-saving bundle. So what a thoracotomy is you're extending that line along between the ribs, joining the two thoracostomies up, and then that allows you access to the heart, to the lungs and the thoracic cavity, allowing you to do a few procedures. There are a number of different procedures that are identified that could possibly be done, but the ones that sort of stick out and the ones that some places would agree to more readily is that first you're wanting to potentially identify whether there is a tamponade, and if there is, release the pericardial sac, let the blood out and allow the heart to beat again. So could your cardiac arrest be due to something compressing the heart, not allowing it to beat? The other thing is, if you've got a hole in your a hole in your heart, you can put a finger on it or suture it until you get some cardiothoracic support to try and deal with that, try and prevent further bleed. And then you may even want to put some pressure on the descending aorta in the thoracic region just above the diaphragm to try and restrict the blood flow to the peripheries and allow the brain and the heart to be perfused better. So those are the potential options they are. This has been, over the years, a very controversial decision to make, and it's quite a difficult decision to make, and one that we've had to wrestle with. So the first question to you now: would you proceed in your department, in your practice? Would you proceed to a thoracotomy? And there is no right answer to this, but it's something that needs to be considered. I'll give you a few seconds to answer that. So getting some results coming in there. Just give you a few more seconds to continue to ask the question, answer the question. Okay. So most people are saying yes, and I think this reflects a big change in what is currently, what was previous advice or thought to be best practice. So I think it's a very interesting thing. And remember I said there's no right or wrong answer to it, and we're going to get to that at the end, talking about your department, knowing your situation, what you have available to you, who you have available to support you if you do make this decision. So there's a number of considerations that we need to have answered. It's not right to say yes for every department. It's it's dependent on each department, each situation. So we're going to talk about that. But before I come in with anything more, I'll be quite keen to understand if the panel have had any experience dealing with this, if any of the retrieval guys have had to do any of this type of procedure, if they've done pre-hospital, and see if there's any expertise from that point of view or opinion from that point of view. So why don't we open it up to the panel? If there's nothing, we'll plow on.
So I think we've considered it a few times in our department for a variety of cases, and on reflection, what I'll probably say is what Peter's mentioned before, is that pre-brief beforehand. If you're able to mention it, say that this is a potential intervention we're going to do, I think you allow people the head space and bandwidth in order to take that on. When you bring it up in the middle of a resuscitation, it can sometimes throw people. So I think getting it early is important. But also as a trauma team lead, you need to keep the indications clearly in your head. You can get completely cognitively overloaded in these scenarios. So sometimes having a discussion with another colleague to say, this is what I'm considering. So you're kind of voicing it together. But as a TTL, you have the end decision. So from my experience, it's that pre-brief is really important for any sort of intervention or an intervention like this that we're considering in the emergency department.
What I'd like to say is that a number of years ago, this was something that you would have probably been hugely criticized for doing, especially in a pediatric patient. And time has moved on. The discussion over pediatric trauma and the management of pediatric trauma has changed significantly. And Stephen, he's part of this talk, so obviously we're sort of singing off the same hymn sheet here. But these considerations that Stephen has mentioned are legitimate. I mean, we have to have this conversation. There is evidence out there. It's not overly strong evidence, as any pediatric study in this kind of area. It will be small numbers. But there's two studies that have systematic studies that have shown that for patients who have penetrating trauma, there is about a 10 to 13% chance of survival. Some of those have looked at whether there is signs of life at the time of presentation or initially, and then there's loss of circulation, and those show a higher percentage that potentially survive, but the overall numbers are still sort of 13.4 to 10.2%. If you have a look at the blunt trauma, so they've come in with a blunt trauma to the chest, but they've had bleeds. The survival rates are very low, and in some studies most studies have deemed that it's unlikely to be of any benefit to do a thoracotomy on a trauma patient that has got a blunt trauma. So there is some evidence coming in there. We have seen it. I worked in Birmingham previously where these have been done in children. And as Stephen has said, in our ED, we have considered it on a number of patients who've come through, but not actually done one. And I think that's a key thing, is that it needs to be part of your consideration. It needs to be part of your team's discussion and your simulation training, so that when you have a trauma coming in, you can say to your team prior to arrival, if this is a penetrating trauma and they've had signs of life and the downtime is less than X, which we'll get to in a second, then we will consider opening the chest. That prepares the team for the potential trauma of opening a chest, because this is not an insignificant procedure to do. So your team need to be ready for it. And there's a thought process behind it. As I've said, you've already tried all your life-saving bundles and you've been unresponsive to further resuscitation. This child's still in cardiac arrest. And the algorithm for the consensus study on pediatric traumatic cardiac arrest would go on to the arrow points on down to consider thoracotomy. Now, it doesn't exclude non-penetrating or blunt trauma. It just says especially in penetrating trauma. So there is still a consideration that can be had there, but the evidence is mostly for penetrating injury. There are a number of things that you have to take into consideration when deciding to step into this. Firstly, do you have the expertise within your environment? That's the people to do it, all right? To make that decision, having the plan there, so that you know what you're going to do if you make this decision, because you've got a very short window to try and make this decision and do it before the effect of this can be benefited from. But you also have to have the expertise. Who's going to take over this care? So you say you open up this chest and you put a finger on a hole. Who's going to take over and close that wound for you? Do you have the expertise within the hospital to deal with what you find after you've opened this chest? Or do you have the ability to get them in? Do you have the equipment available to you in your department? And if not, and you're considering this, then this is one of the key areas that you need to consider. Now, this is a procedure that pre-hospital teams can do and have done, and we've known people who have done this in the community. But again, equipment is essential. What's your environment? Are you in a place that with people that can support you in this? Will your team go along with you? As Stephen said, this is often a discussion that doesn't come down to one person. It comes down to discussing with the team that's there. By the time in a hospital, you have got to the stage of wanting to open the chest, you should have other people there that you can ask. There's a resuscitation team. So you're making a decision together. The elapsed time is one that is important. So some guidelines would say if they've had a cardiac arrest within 15 minutes of you cracking the chest, then that is the kind of time frame you need. In our department, we've decided for 10 minutes. So if a child has a cardiac arrest within 10 minutes of us deciding to crack the chest, then that is something that we would consider. And that's if there's a penetrating injury. So the child has to had a traumatic cardiac arrest with a penetrating chest injury and cardiac arrest within 10 minutes, no longer than 10 minutes before we would open that chest. You got to remember that you're at a state where this child is not surviving the resuscitation at this point. And I think this has helped a lot of people sort of swing around to start considering, yes, we will consider this procedure, is because this child is going to die without an intervention. You're on your last straw here. You haven't responded to anything else. So are you going to crack the chest? And that is a question that then needs to, because you're going to have to justify this response at a latest time. Some people will criticize you for doing it, no matter what the situation. So you're going to want to have your guidelines written out. You're going to want to have a clear understanding that if I don't do this, the child is dead anyway. And therefore, cracking the chest is giving them that little bit of extra time or potential chance of survival. And that's what you're going to be explaining to the parents when they come in to see their child with their chest open as well. So these are the things that you need to consider when you're thinking of doing a thoracotomy. Communication is key with your team. Being prepared, having an agreed process of who you're going to do a thoracotomy on, having an understanding and simulating this with your team, so that the communication is clear, that the expectation is there, and that your resus is set up for it. There's no, as I said, no right or wrong. We're not telling you that you have to do this. We're telling you that this is what we've decided with the limited evidence that we've had, as this is a last step for a child to potentially get a life-saving treatment. But it takes a lot of courage to make that decision. And the courage comes from repeated practice, repeated discussions, having something that will back you up from that decision, and having your team support. Anybody else want to say anything before we shut off on that and summarize this talk?
Costas has got a hand up.
Oh, Costas, yes.
Sorry, my Zoom was down when you asked the question. I would say part of it is getting over the hump of, I'm going to saw someone's sternum open and open it up, especially in cases of penetrating trauma where it's found to be more useful. And we do say, do sim, make sure your team is set up for it, but very few people make the leap and say, well, actually, what does that translate into my emergency department? How does it translate? What came out of the events of the Manchester bombing, and in smaller part after the Southport stabbings in the UK, is that actually we are thinking about doing clamshells more and more, but we don't know where the kit is in our ED. It's locked up. There's codes to be pushed through. There's not enough people who have, are brave enough to take the bag and roll with it once it's done. So it's vital, much like we have a difficult airway trolley increasingly, and we all know where it is and what each drawer includes, that we have a clamshell kit in our EDs. We all know where it is, and we run a sim about it on a regular basis so that people know where it is and take that side of practical issues in terms of human factors management out of the equation. And we all do it because it's such a rare occasion, unless you live somewhere with major trauma, lots of trauma, such as Johannesburg and stuff like that, that we, in the UK, we don't do enough of them. So just a bit of advice to set up your departments. HEMS, so pre-hospital teams are set up much better for it because they expect to see it on the roadside. But once in ED, it's such a chaotic workspace that we rarely set up for it. They would know where the kit is.
I think the evidence base for its use is definitely increasing. It's still scant, but that Salinger paper, when you looked at, you break it down into some specific ones. So penetrating trauma with signs of life, either at ED or pre-hospital, have a survival rate of 31%. I thought that was phenomenal. We've looked at the actual raw data, and we're trying to update the systematic review, and that's the actual figure. So for me, it's, if it was my son that was stabbed who came in and had loss of output in the ED, what would I want done? And I would probably say give him the best chance, because survival is pretty poor if you don't do it. So I think you're advocating based on the evidence base that's out there versus the fact that this is a true halo procedure, in that who has the expertise and the kit to do this in the time it takes, because this shouldn't take 10-15 minutes. You're talking minutes to get into the chest to do your intervention. So it's complex, and that's why I don't think there's any overriding push to do it. But certainly the Manchester Arena bombing made me think about it, as I don't think you'd probably get away if the indications were met by saying you're not doing it because you're not comfortable with it. We're trained physicians, and you need to have your team set up or somebody in the department that is able to do it. So there's lots of things to think about for these cases, which is why we bring them up. So I think in the interest of time, Dr. Collins is who expertly led that resuscitation, is going to take some key messages, and then we will end this session.
Thanks, Stephen. Yes, apologies I wasn't able to join the start of the session. Thank you to the team for presenting. I am looking after a little one in the background. If you hear any noises, it's not just that I didn't want to watch myself on video. But I'm Julianne Collins, also a consultant in paediatric emergency medicine in the Children's Hospital with Stephen and Tudor. So I suppose, yes, just a few quick take-homes. Thanks to the team for sharing, it was the best available evidence and their experience on what are really contentious and topical issues relating to trauma, but through a paediatric lens. And there's plenty of food for thought, I think, there to take back to your own departments and teams and look at your contexts. I think the other key thing to take away from it is how important it is to promote that psychological safety within the trauma teams, and that's the flattening of the hierarchy and creating those safe space to allow and enable discussion to ensure the best outcomes for the patients. And also, I think we've talked about a little bit there at the end about halo procedures, which is those high acuity, low occurrence procedures and what we do. And I suppose it's that day that we're maybe all preparing for, that we hope never comes, but it may well do. And I think, as Costas mentioned there, it's sometimes about making that leap, and the guys mentioned all the preparation you can do. And I think the other key is, as was mentioned as well, about getting your help present early. So I think those of us who maybe aren't used to dealing with open chests on a daily basis would certainly feel more comfortable proceeding if we know we have our paediatric surgeons by our sides or our cardiothoracic friends to sometimes just help build that confidence, even though you may have the competence from practicing the skills. But it's about that psychological leap sometimes, and and making the decision to go ahead and what we're going to do once we've done that. So I know in the interest of time, I'll leave it there, but thanks again to all the team and to Chris for the opportunity for sharing this learning, which was recorded at the Northern Ireland Paediatric and Adolescent Trauma Symposium Conference in September. So thank you all for listening. If there are any final questions.